First call is not there?
Doesn't look like.
Okay.
No, he has not come. I think we can start.
Okay, no problem. You can just.
So welcome back, everybody, after the Diwali vacation, and we'll have Dr. Madhu again taking us through some interesting cases as he calls them. Madhu, go ahead. It's all yours.
Okay. So good morning to everyone. The pattern is just like the same. I am presenting interesting cases, challenging cases, where the diagnosis was not easy at the beginning, but after thinking or what do you call exercising our brain for some time, may be able to come to the diagnosis. Now, there is no monologue and dialogue. You can interrupt anytime. You can ask questions. There's anyone want to speak or make comment, you can unmute themselves. So I now start sharing my screen now. Are you able to see my screen now?
Yes, yes.
Yeah. So we'll start now. So the first case is always a short case because I allow some time for the people to join. The second case will be a really tough case. So first case is a 40-year-old man. He gives history of sudden onset of headache and vomiting 2 days prior to admission. He complained of blurring of vision, which improved with closure of either eye. He also complained of tinnitus and mild deafness in the right ear and numbness on the right half of the face. This is a story, fairly acute onset, headache, vomiting, associated with defective vision which improves by closure of either eye, or likely may be suggestive of diplopia, a tinnitus of the right ear, numbness of the right side of the face. So I'll go to the findings now. This is the position of the head he had. He has got head tilt towards the left side. On examination,
do we want to ask any of the students or anybody wants to discuss blurring of vision which improves with closure of one eye? What does that mean? Does anybody want to take it up? Raise your hands.
From the history, what do you think the possible side?
From the history, anybody wants to think of anything or say anything, you can raise your hands. Mansi, do we allow people to raise their hands? Is it allowed or not?
Mansi? Initially, they could unmute themselves and speak. That is the pattern we followed.
Anybody wants to say? Okay, somebody is Sanju John wants to say something. Let me
please.
Let me ask him to talk.
Yeah, please.
Dr. John, you can speak.
Yeah, HICT science with sixth nerve cranial palsy, sir.
No, it can be any of the extracorporeal cranial nerve palsies. You only say it's for a diplopia, which may be third or fourth or sixth, which we can't say. That is why the blurring of vision improves by closure of one eye.
So the important point which Madhu is making is when somebody has blurring of vision and it improves with closure of one eye, it means even if the person is not saying diplopia, it is he's not seeing well with both eyes. That means it is something to do with the alignment of the eyes. So it has to be something wrong with the alignment of the eyeballs and not with the optic nerve or the vision. And therefore it is any of the extraocular muscle palsy. Sometimes in skew deviation also you may get, but more likely an extraocular palsy. Then
he has
depending on what it is, if he's showing the person's face, he showed, what do you see that? Let's go to the next slide.
It is tilted to the left side.
Tilted, yes. So when it is tilted, John, what will you think of? which cranial nerve pulses do you get tilting of the head? And why? Dr. Sandhya,
Anyone want can go ahead?
anybody just raise your hands and you can speak.
Hello.
Yeah, tell you can speak.
Good morning, sir.
Yeah,
It's fourth nerve palsy, sir.
very
On the
good.
opposite,
Okay, right.
the opposite side.
Okay, that means he has got a right superior oblique palsy here, right?
Yes, sir.
Okay, very good.
Very good.
Now he has also got tinnitus to the right ear and numbness to the right side of the ear. So where do you
Tinnitus, sir, tinnitus is eighth nerve palsy
correct?
on the same side, and numbness would be fifth nerve palsy on the same
Okay,
side.
right. So you're likely to have fourth, fifth, and probably eighth also is affected, correct?
Yeah. So it can be anything in the auditory nerve pathway. It doesn't have to be eighth
Yeah,
nerve.
correct, exactly.
It can be
anywhere
anything along the hearing pathway.
correct, right. Now let us go to the findings now. Yes, head tilt to the left side. It's got, as suggested, he had right superior oblique palsy. And he has got decreased pain on the right half of the face. But the corneal reflex was normal on both sides. And he had mild gait ataxia, no neck stiffness, but Kernick sign was positive. The other findings.
From this, yeah, where is the lesion and what do you think could be the cause?
Yeah, anyone can answer. You can take some time, 1 or 2 minutes to think about it and answer.
So first, let us see the localization. Where do you think?
Yeah.
Is it intraaxial or extraaxial?
Anyone want to answer? You can answer. Okay, then I will go ahead, no problem. Now let us see the lesion. As Sudhir was telling, is the lesion extraaxial or intraaxial? Okay. If it's extraaxial, where could be the possible lesion? It could be the. Is there some disturbance coming? I don't know. No. So if it's extraaxial, somewhere in the apex of the right vitreous bone, we can explain the right pistina, right superior oblique weakness as well as tinnitus to the right side with the extension of the lesion of the C-can. Agree? Something in this apex of vitreous angle region going down to the C-angle location. Right? Yeah. Do you agree with that possibility?
Fourth now, I'm not happy with Petrus because Petrus should normally cause 6 now palsy, but like what we get Grad-Enigo syndrome.
Yeah, right. But this fourth nerve is also just adjoining with third, 3 and 4th all when it goes together. So it can get one after another. Maybe one may be affected, one may not be affected. There's one possibility I'm keeping.
Yes.
Okay.
Could be.
Okay. Let us see if there anything odd in that localization.
The absent corneal is.
Yeah, that's absent corneal is yes. So how to explain the attacks is one problem. And why is that corneal reflex is normal on the right with surface perfect on the right place? These are the two problems with extraaxial location.
So I would think more likely intraaxial.
Okay.
And with the acute onset, then we need to think of a cavernous hemangioma or something, some bleeding or something acutely, something has happened.
Yeah, but the point is first is the localization. That's what I'm talking about. Okay, let's come to the intraaxial location. Is it a right pontine lesion? Anyone? A right pontine lesion will explain the right fifth nerve, ataxia, and right eighth nerve possibly extending to the cochlear region of the right side. But is there anything odd in that condition situation?
The fourth nerve.
The fourth nerve. So we can't explain the right fourth nerve because if the lesion extends to the midbrain, you get only the contralateral fourth nerve, left fourth nerve, yes. But here the fourth nerve is on the same side. Okay, so then how do you explain that possibility? So it's not right pontine lesion, unlikely to be an extraaxial lesion. So any other possible site you want to think about it?
Um, is it definitely a fourth nerve and not a skew deviation?
No, definitely a fourth nerve.
Okay.
Okay, let us go. Anyway, I'll tell the localization later on, what I thought later on. But what do you need now? What else you need? History of headache and vomiting. The first possible is some kind of a bleed or either intracranial bleed. So took a CT scan. CT scan did not show any subarachnoid hemorrhage. And the pons was normal, nothing extraaxial.
Um,
Pons is normal. Pons and medullized.
Something near the cavernous sinus. The cavernous sinus seems a little full on the right side, but I'm not sure.
That is normal. Okay, I'll show the CT scan now. Now see the CT scan. Look at the midbrain. It's got a lesion in the left midbrain in the inferior quadriculus. Okay. Now, how to explain the finding? That's the thing I want to brought the case to you. Did you see the localization? As Sudhir was telling, it's a cover, it's a bleed there. Most likely, maybe a cavernoma, which is blood in the location. In the lower brainstem on the left side, midbrain on the left side. Now, see this again, the MRI, the picture showing the follicular lesion on the left side. Okay, very well visible. Now, let's see the explanation for each one. How to explain the right sided tinnitus and decrease sensation right side of the face. If you got pain loss on one side of the face, it need not always be indicated dyspnea involvement as to. It can be due to the effect of the spinal nucleus or its tract on the same side, the brainstem, or the ascending pindothalamic tract on the opposite side. For example, if you know the pain fibers descend down and at various levels into the nucleus and cross to the opposite side and ascend. So, for example, as this is all you know about it, just for clarification. The upper part of the fibers in the upper part of the face or the posterior part of the face, they descend most downward and then the caudal part of the spinal nucleus, the middle part of the nucleus, and then around the feet, the upper part of the nucleus. Then they cross to the opposite side and form the ascending pindothalamic. If somebody has got a sensory loss on one side of the face, the lesion can be either in the spinal nucleus on the same side or ascending pindothalamic tract on the opposite. Correct? So in this patient, he has got loss of pain on the right side of the face, indicate that either the descending tract or nucleus is affected on the right side, or pindothalamic tract is affected on the left side, which after going cross through the midbrain and pass. That is one possibility. Suppose the patient has loss of pain on one side of the face. In this situation, how to differentiate whether it is due to the descending tract or trigeminal nucleus is affected, or the pindothalamic tract is affected opposite. That is a clue to your mind. If it is the descending tract of the nucleus, the corneal nucleus also will be locked in the same. Because the corneal afferent pathway goes to the spinal tract. Whereas corneal nucleus may not be affected or intact with deletions in the pindothalamic tract, because that pindothalamic does not carry suppressed pathway.
Madhu,
Yeah.
there is some disturbance coming.
Yeah. There's some. I was also.
Can you try logging in and logging out again?
Yeah. That's what I log out and log in again. Just 1 minute.
Try that.
Yeah, I'll log out. Just 1 minute.
No, whatever I am talking is my voice is also getting disturbance.
Yeah, correct. That's what I observed also. Is it some problem there? Mansi can sort it out.
Is everybody's sound getting disturbed? Or is it only one?
I think I'll just start once again anyway. Just log out and then come back again.
Okay, so let me also let us all get Okay, let's hope.
Let's start once again.
Hmm?
Where was that thing? PowerPoint does not see. Okay, can you see the slide now?
Yes.
Yeah. So how to spend the now the first one. So this I have been talking about. Lesion on one side can be due to either the descending tract or nucleus affect on the same side, or ascending endothalamic tract on the opposite side. Now, what I'm trying to say is that if loss of sensation is due to the descending nucleus or the tract, the corneal reflex is also likely to be lost on the same side. On the other hand, if the loss of sensation is due to the contralateral ascending endothalamic tract is affected, the corneal reflex will be preserved. So that's the point which I talked in the history and examination. A loss of sensation, but corneal reflex is normal on the right side. So telling you that likely to be in the ascending endothalamic tract. Now let us see the deafness on the one side. There is entity called tactile deafness, that is inferior collicular lesions can produce partial deafness on the contralateral side. Here the pure tones are sprayed, mimicking pure word deafness, and you can have tinnitus also on the side. This is one of the common complaints what you see in superior subulnar artery infarct. So I forget about this one. So the final site of lesion is this. There is a lesion here in the ascending the low ascending endothalamic tract, producing contralateral pain loss. It is affecting the fourth nerve here, producing the contralateral superior oblique muscle paralysis, and the tectum inferior colliculus producing the contralateral deafness and tinnitus. So this is a lesion here causing the problem in this patient. That's exactly the site of hemorrhage in this patient. So any questions in this case? It's a good case for localization. I did not show the video of the patient.
Yes. It's a good, very nice.
Dr. Saksham Jain, you can unmute yourself. He has raised his hand, so he can unmute himself and talk.
Anyone can unmute and speak, no problem. Yeah, please.
Sir, there was headache and vomiting. So,
Yeah.
the raised intracranial pressure can explain
No, he had subarachnoid hemorrhage. He had a cardiac sign was positive, and the bleed was actually inside the brain, seeping into the subarachnoid space. That is why he had a headache and vomiting.
Okay.
Raised ICT would usually cause sixth nerve pulsing, not fourth.
Correct.
But it's very nice explanation how you get contralateral. A nuclear fourth nerve palsy is contralateral.
Contralateral. Because the pathway takes this, the one tail lamp goes to the opposite side, inside the brainstem.
Dr. Patil wants to speak.
Yeah, please.
Sir, a Kernick sign in this patient, what it indicates?
It indicates a meningeal irritation. Sometimes in meningitis, you may get either neck stiffness, more often you get neck stiffness. Sometimes Kernick sign alone may be positive. Very often what we do in practice, we just look at the neck stiffness and leave it at that time. Don't do like that. Sometimes Kernicks may be positive. So because there are three types in subarachnoid hemorrhage can present. Many of them, if you read the old textbook of medicine, you will know that. One is a classical apoplectic form. Second is a meningitic form. They are present with meningitis like picture only. Third is lumbago-sciatic form. That's the original term they call. Lumbago-sciatic means they come with low backache and radiating pain. And the patient's got subarachnoid hemorrhage. So an acute onset of low back radiating, always keep this possibility also in mind.
Okay, sir. Thank you, sir.
Okay. Now I'll go to the next case. Siddesh, shall I go to the next case?
Go ahead. Go ahead.
Yeah. This case is a little tough case. You have to really concentrate. You can take some time. When I show the video, if you want to see the video once again, I can show the video once again. This is cases from Travancore Medical College where I'm working, and the courtesy is Dr. Rajesh and Dr. Roy who gave this case to me. It's a 65-year-old diabetic man who is a chronic diabetic with borderline renal dysfunction. His initial serum creatinine was 2. He came with a history of walking difficulty for the last 2 months. He said he has to put extra effort to move his legs forward. That's all what he said. But he was carrying on with that difficulty. He did not bother much about it and did not consult any doctor for this complaint. He started losing weight and consulted the local physician. He investigated and found that he has got a worsening renal function. Serum creatinine shot up to 5 in 2 days' time, and he was referred to the nephrologist in our hospital and was being planned for dialysis. For dialysis, an arterial shunt was put in the left elbow 2 weeks, that's 2 weeks prior to we seeing the patient. And according to him, on the same day, he developed, after putting the shunt, he noticed numbness and weakness and total weakness of his left hand. I did not believe that history myself. I asked him again and again. He said it's immediately after. Many people tell like that, which may not be correct. But anyway, he said only for 2 days it is there after putting the shunt. He had no complaints regarding the upper limb. The walking difficulty, which has been there earlier, remained as such for the time, which has been there for 2 months. Had no root pain, no complaints in the right upper limb. There is, I asked her the history of precipitation. He said that it is there, but I am not very sure about it because I got the answer on a leading question. He did not volunteer on himself. So this is the story of the patient. Acute onset of weakness of the left hand and numbness, and previous history of walking difficulty with probable stiffness. Now go to the examination of the patient.
Wait, no. Let people analyze it just now from the history. So anybody wants to try? Dr. Unni Krishnan? Dr. Unni Krishnan, you can speak.
Yeah, whatever, let me be wrong, no problem.
Yeah, I mean, we learn in guessing. That is the history, how to analyze.
Yeah.
The thing is, you have to understand that as soon as the patient walks in and starts speaking, your brain has to start thinking.
Again, correct. So logically, yeah. Whatever you think is some dragging of the feet and walking difficulty was there, probably bipyramidal signs. It has got weakness of the left hand. Probably we think a cervical radiculomyelopathy. That's one possibility you have to keep. That's what I'm just thinking from history.
How long was the dragging of the legs before?
No, that his history was that he did not drag. He said he has to put extra effort on walking. That's all what he said.
And since when?
That's for 2 months prior to the present.
And that extra effort, that didn't happen suddenly in one day.
No. That didn't happen suddenly in one day.
Okay. So from this history, I mean, nobody seems to want to talk. What I would think is, if the person, his history of extra effort in walking suggests possibly more likely upper motor neuron, but we can't be sure. It also,
Exactly.
the guy is diabetic, so we shall also keep in mind the possibility of stiff person syndrome.
Okay.
And maybe with the weight loss, maybe possibly early developing diabetic diabetic femoral.
Even if some hip flexor weakness patient also, they give this sort of a complaint that put extra effort to push the feet forward.
Okay, but
I think
with the way his left hand weakness, so normally we'll think that lower limb dragging heaviness and left hand, so it should be cervical cord. But I am not so sure that the two are related, because one history is insidious gradually, and this hand has happened very acutely after the shunt. So it could be that I have seen patients develop ischemic neuropathies in the hand after shunt is
Yeah.
placed, the blood
Yeah.
supply gets diverted and you can get median, ulnar, radial, whatever
Yeah.
ischemia of the nerve. So let's see what
Yeah.
examination
Yeah,
shows.
that's I also considered that possibility for the shunt ischemic involved, but total weakness of the hand seems unlikely to. It's a little odd. Anyway, let us see the
Yeah,
findings.
Dr. Lakshmi also is saying
Yeah.
the same thing.
Yeah, want to say something?
Weakness of the hand could be ischemic neuropathy. Yeah.
Yeah. Right. Okay, let us see. His deltoid was, you see the emaciation is emaciated. Biceps was normal, deltoid normal. Triceps was normal. Biceps was normal. Triceps normal. The wrist extension was normal on the right side. His complaint was on the left side. But he has got a complete wrist drop. He could not elevate the wrist. He has got a finger drop. That even the right side, the finger flexors is weak. The finger flexors are also weak mildly on the right side. Do you see that? You could
What is
easily
the
over.
left brachioradialis?
No, I'll come to that. I'll come to that. Just 1 minute. This is on the right side. Even the small muscles were weak. Now come to the left side. All introsea were weak. He could not abduct. He could abduct upon his longest. Waves are all weak, zero power. He could not extend the thumb. He could not flex the thumb. The finger flexors were also weak. The wrist flexions little bit power, say just 2 power. The brachioradialis, I'm trying to hold the hand in the mid position. It will not remain in the mid position. See, it got automatically supinated. That means the pronated tendency is weak. See, it goes like that. So I'm checking again. The pronated is so much weak. Supination is also weak. Cannot keep it supinated. He cannot keep it pronated. That's weak on the right side as well. It is weak. His supination, pronated is weak, and supination is also weak. Now the pronated thing is weak. So check the finger flexors once again. They're also weak on the right side. Small muscles are also weak on the right side. And former sense is positive on the right side. Left side you can't test because it's so much weak. And the introsea were also weak. The lower lip, the tone was normal. And the tone was normal. Hip flexion was weak, about just 3 power, not even 3 plus. He cannot hold it up, right? Knee extensors were 4. It's also weak. That's also 4 power. Dorsiflexion was weak. Plantar flexion was also weak. EHN was weak. Plantar flexion was better compared to the dorsiflexion. Same thing on the right side. That got amputated diagonally weak. Reflexes, biceps normal, supinated normal, bilaterally normal. Triceps is also normal, but less on the left side compared to right side. Can you see it? You can see the triceps. It's only 1 plus. It's also well elicitable, probably 2 plus. Finger flexion reflex was absent. Knee jacks was elicitable, not 1 plus only, just elicitable. Without reinforcement, you could elicit it. Angle jacks were absent. He's a diabetic. I could do it only the left side. He's absent. And the plantar was upgoing on the left side. Repeatedly check again, consistently upgoing. Right side, I could not, because I got an ulcer and all, I couldn't put proper effort on the side. Abdominal flex just elicitable, easily fatigable or diminished. Now, sensory system, I'll tell you what the sensory, because you can't understand the language. He's not able to feel anything in the left hand up to the wrist. Pain, touch, temperature, everything is lost on the left hand up to the wrist. And the right side is also diminished, but mainly on the right little finger. That side is not able to appreciate, all other areas able to appreciate. So I will skip that part because sensory types, I will tell you what the findings were. In the lower limbs, it was in a stalking distribution because it's impaired distally and it's got a level up to the knee, the region of the mid shin. The right upper limb, it was less on the little finger. After that, I'll tell you the level at which it becomes appreciated. That's the level he said is more. Somewhere around the wrist joint. Then of course it's just like a distal part. Same vibration is decreased on the right little finger. Other fingers not. On the left upper limb, all the fingers it is lost. Not able to appreciate. There he is able to appreciate the wrist. The right little finger is less compared to the thumb. Embedded in both feet. Feel able to feel over the knees. Johnson is also embedded in the left right little finger. Anyway, let's skip that part. Lower limb, of course, is embedded. Now, examination in emaciated old man. Hymen function is normal. Cranial is all normal. Motor system. Tone normal in the biceps and pronators. Flaccidity of the left wrist, which you also. Normal tone in both the lower limbs. Coming to the motor power, it'll spend some time on it. It's got great zero power of the thenar, hypothenar, introshi, finger extensions, finger flexes of the hand, and extensions of the left thumb, and extension and wrist extension, and grade 2 power of the wrist flexion. In fact, every muscle was weak and the left below the wrist, except the wrist flexion, which is grade 2, not 0. All others are 0. But in the presence of, and also weakness of both pronation and supination. Pronation is more severely weak, could not keep the hand in the forearm in the midpoint position. Normal power of the deltoid, biceps, triceps, and brachioradialis. Right upper limb, weakness of the finger extensions, hypothenar, introshi, and adductor pollicis, and mild weakness of the thenar, finger flexion, pronation, supination. In fact, almost the same distribution, except that severity is much more on the left side. This is the findings on the left side. You want to spend some time on the power, I can show once again. If you want to see the video once again, I can show the upper limb power, not all the things. You want to see it again? Anyone?
No need, I think.
Because it's a tough case, that's why I'm asking you to. If you want to examine once again, you can examine it.
No, let's analyze it, and then if somebody wants to think. So first of all, now.
See, just a minute. I'll go to the rest of the findings also. Okay. I gave some time to think about this pattern of weakness. Now to the lower limbs, grade 3 power of both hip flexors. All of the muscles are 4 to 4 plus. DTR, biceps supinated eject 2 plus bilaterally. Triceps 1 plus bilaterally, slightly less on the left side. Knee ejects 1 plus bilaterally, both angles absent. Abdominals only flicker of movement. Plantas definite upgoing on the left side, indefinite on the right side. Sensory system, upper limbs, left upper limb. Severe loss of pain, touch, vibration, and position in the left hand. The pain and touch level was at around the level of the wrist. The right upper limb, impaired touch, pain, vibration, joints in the right little finger, but mild impairment touch in the whole of the right hand is a little less. Lower limb, stalking type of sensory loss for all modalities. Now this is where is a localization. Now you can take some 1 minute and think about an answer.
Yes. Anybody wants to raise their hand?
If you want to see the muscle power again, I will show that once again. Keep the slide in the top so that I can hear.
Dr. Lakshmi, Dr. Unikrishnan, you can speak.
It's not an easy case. Okay, if nobody is coming, shall I discuss?
Yeah, so let me try. You know already. So
Yeah.
it is very difficult. I mean, it's difficult to put it into, is it upper motor neuron or lower motor neuron? From there, it's a little problem.
Yeah, correct. Exactly.
The lower limb seems to be a combination of UMN and LMN because
LMN may be part of the peripheral neuropathy he is having earlier.
Yes, that's why flexes are not brisk, but planters are down. Plantar is up, and the power weakness is not fitting into any particular element pattern. Therefore, it must be with the history of heaviness in the legs. I think the lower limbs are definitely upper motor.
Correct.
Now, in the upper limbs, we have a problem. Initially, I thought the way you described the left upper limb, it looked all like an ischemic neuropathy, and you are getting median, ulnar, radial, everything below the elbow. But the problem is the right upper limb. The right upper limb is also affected. That obviously rules out ischemic neuropathy. So then now we come to, can it be mononeuritis multiplex? No, so many nerves in the both upper limbs, only distally, and nothing in the lower limb. It cannot be a mononeuritis. Therefore, I would say it's something like a radiculomyelopathy. So cervical part seems to be radicular, mainly C7, C8T1, C8T1 maximum, but C7 little bit. The tricep jerk is reduced.
Yeah.
So triceps power is all right, but pronator teres is weak. So it looks like C7 also is affected, but less, but mainly C8T1.
Right.
And looks like a quad.
Okay. So any other students want to analyze anything?
Dr. Unikrishnan, Lakshmi, you have raised your hands. Why don't you speak? Dr. Jain, you can unmute yourself.
So this pattern of lower motor symptoms in the upper limb and upper motor in the lower limb, this is seen in syrinx.
Yeah. Okay. Right. I'll come to the discussion later on. Okay, syrinx. But you find the type of sensory loss he has, the pattern of weakness confined zero power the distal muscles alone. Is it forming a segmental pattern? No diffuse anesthesia. Reflexes are well beating. Syringomyelia and all reflex loss there. Or unless syrinx is confined to only one particular segment, involving all the new neurons in that segment. That's also unusual. I'll come to that point.
So distal peripheral nerve pattern of mononeuritis multiplex also possible.
That's a possibility.
So for CAT1, the triceps and brachioradials are not involved. So for CAT1, C7 radiculopathy, you should have some involvement of triceps and brachioradials. So most probably a mononeuritis pattern or MMCB pattern we can have.
But you wanted to see CAD1 pattern, you said?
The CAT1 for CAT1 radiculopathy, sir, the triceps brachioradials should be involved.
You want to say CAD1 radiculopathy in this patient?
Not, sir. No, not CAT1. Most probably peripheral nerve with a mononeuritis.
Okay. I understand. You said not radiculopathy. Agreed. Perfectly agreed. Correct. So let us analyze each one point one by one. Let's verify localization. Let us analyze upper limb weakness first. First question, is it LMN or UM in the left hand? Anyone come to you with acute onset of severe weakness of the one whole hand, the other to confine the distal part? One possibility should come to your mind is a cortical infarct, like hand and can be so restricted confined to the left hand alone, sparing the proximal muscles. So let us see, but the weakness is not in the distribution of the human pattern for a pyramidal lesion. I'll come to the cortical localization later on. Because he had so severe weakness of the finger flexors with spared deltoid and triceps. Because as you know, the pyramidal lesion produces predominantly weakness of the gravity muscles. The flexus cannot be zero. And if it is zero, the other muscle also should be affected. If it is a pyramidal lesion occurring anywhere in the pyramidal tract, for example, cervical cord. But this is not applicable for a cortical localization, where all the distal muscles are localized to one particular area. The common collision is such that alone may be affected. So that's what I said, possibility of cortical lesion cannot be ruled out. But there are other points against a pyramidal lesion, UML lesion. He's got total loss of sensation for all modalities. In a cortical localization, you don't get loss of vibration and loss of the primary model like pain and all. That will be spared in the case of cortical localization. But can occur with a localization elsewhere in the system. Thirdly, instead of spasticity, you get a flaccidity to the distal muscles, and the finger flexion reflex is absent in this patient. So these points favor more like in an element lesion affecting the left upper limb and also the right upper limb. The right upper limb is also affected again speaks against a cortical localization. Now let's come to element each one. Is it a radiculopathy first of all? What are the points against? Because its motor weakness and sensory loss are not in the distribution of the root. That's the point. See, it's not CAD1. You can also think of C7 also. Why not C7, CAD1 radiculopathy? The fingerprints are also weak. That way you have to think about it. I'll tell you the point. He had severe finger extensor weakness to the extent of zero power with normal triceps and normal triceps reflex. Because finger flexion is also supported by C7, triceps is also supported by C7. So in this pattern cannot go with the radiculopathy. CAD1 agree with you, but not C7 involvement here has got so severe disparity. No, that's unlikely. Now let's see whether it could be in the plexus lesion. If plexus lesion, which will be the region affected, it could be middle and lower trunk and explain the findings in this patient. The lower trunk can explain the all muscles, finger flexors can be explained, and the middle trunk for explaining the finger extensor weakness as well as the wrist extensor weakness. What is against that possibility? Again, unlikely because the weakness of the finger extension with spared triceps muscle, because the middle trunk is the one which is supplying the triceps muscle also, because it's contributed to the C7. Middle trunk is formed by the C7, and C7 is supplying the triceps muscle. And it's got a normal triceps reflex, so that is against. That's also against. Now, why can't be medial and posterior cord lesion? Again, that's also unlikely because if it's posterior cord, you can explain the triceps, having the finger flexion, distraction, etc. But the triceps is paired and deltoid is paired. So it cannot be posterior cord. So so that means posterior cord is paired. That possibility cannot explain. Within the posterior cord itself, some muscles are affected severely, some muscles are paired. So that possibility is also out. Now, what remains is multiple nerves. So possible, but the problem is that you have to implicate all the three nerves as implicated. One, radial nerve below the elbow, below the subtalar to the brachioradialis. Ulnar nerve, of course, is affected and sprained. Median nerve at elbow before the subtalar pronator teres. Pronator teres is zero. The other point against radiculopathy is that the pronator teres is also severely affected. That means its involvement is the C6 is also affected. C6, C7 is also affected. C6 contribution is normal, that's also affected. That means it's going beyond a particular route, but it fits in with a nerve because the muscles involved fit in with the involvement of the pattern of nerve. But only thing is the multiple nerves has to be indicated. So the fact that weakness, sensory loss on the right side, if you take again, the sensory loss is mainly in the ulnar nerve. So even though other nerves are affected, main pattern involvement was favoring an ulnar nerve. So that's also point favoring a multiple nerve. So the upper limb, it looks more like a mononeurous multiplex in view of the fact that it is not fitting with either radiculopathy or plexopathy. The plexus either in the cord level or in the trunk level. Now let us go to the lower limb. It goes with human lesion. Both the plantar is upgoing, intact DTR with weak cortices. This is the point favoring human. And of course, weakness is not in the distribution of the nerves. All muscles are affected, as Sudhir was telling. And you can't implicate all the nerves in the lower limb to be affected simultaneously. And the history is also little different. That was gradually progressing or remaining there for 2 months. These other things came recently. So the final localization is pyramidal tract. Where is the pyramidal tract lesion? I don't know. It may be in the spinal cord, it may be in the brain. Because there's no, we cannot say where it is affected. Element weakness in the upper limbs is likely to be most likely multiple nerves. The only point is that if it's a myelopathy and nerve involvement is little not gel with each other, two different localizations, different etiology you have to think. Or more likely you get a radiculopathy. Radiculopathy, of course, you can explain radiculomyelopathy. But the points I told you against radiculopathy holds true. But still, in the back of the mind, I kept that possibility because there are three query, because that can single site can explain both the things together. And this is also against the same points are against intramedullary lesion affecting the syringomelia, because the segmental involvement favor the pattern of a radicular involvement. This radicals arising from the segment. So you can't have a spire which will produce a C7 segment involvement producing a zero power of the finger extensions with the normal power of the triceps. So that's why always the distribution of the muscle power, the distribution of the muscle involvement is the one which helps you to localize whether it's a root or a trunk or cord or the brachial plexus or the nerve. Okay, this much is your thinking in your after examination. So what do you want now? What investigation? MRI cervical spine? It is normal. This is the axial section, normal. At each level, all the levels I have taken axial section, but I'm showing this is all normal in the cervical cord. What else you want now? Any other investigation?
Nerve conduction, sir.
Before nerve conduction, let's localize the pyramidal lesion first and come to the nerve conduction. Nerve conduction is to localize for the element in the upper. That will come to that. Now we have to sort out the cyto lesion with the pyramidal. I told you it can be anywhere. No, we don't know where is the localization. It can be anywhere in the brain, in the spinal cord, or even above the spinal cord. So MRI brain was taken. MRI brain is normal. There is no lesion in the pyramidal tract. Diffusion was also normal. So we don't know where the site of lesion. We know the pyramidal tract is affected, but where we do not know. Well, let us come to the contextual study. You can see all the nerves are affected in the nerve pattern. See this one. This is the result. Right median, right amplitude is low, but left not at all stimulated. Okay, so right median is also affected to some extent. Right radial is again severely affected, left is totally affected. Right ulnar is also affected, both ulnar affected, severe affection on the left side. Lower limb, left peroneal, that's difficult to examine, take into consideration because you've got so much edema and wasting because of the diabetic neuropathy and all. So may not be picked up from the EDB. Now come to the FIB studies. The right median, it is 35, slightly prolonged. All other things are absent, as suspected, because they are not very much low amplitude, means you won't get any FIB response. Now sensory, right median is there, little bit low. So also right radial is low, but all other sensory potential also absent. So right left median, no potential. Remember that particular point. No snap from the left median. Right ulnar, left ulnar, no potential. Lower limb, sural, no potential. Tibial nerve also no potential. Because peripheral neuropathy is likely to be there. So NCV wise, where do you think is the localization? Can it go with radiculopathy? Obviously no, because snaps are absent in all the nerves of the muscles. So then can it be in the trunk or the brachial plexus? The snaps are also involved. NCV wise, No, because she has got, remember this particular point, there is a loss of snap in the median nerve distribution D2. That suggests that the upper trunk or lateral cord also has to be implicated if the potential was lost. Okay, that means we know that upper trunk or the lateral cord is not affected because his biceps, deltoid, or normal power. That means the upper trunk nor the upper roots are spared. So unless that is affected, you won't get a sensory loss in the median nerve distribution. Here the snap is also affected. That tells you that the lesion has to be in the nerve. It cannot be in either in the cord, nor in the upper trunk, nor in the root. You got the point? So that means that he has got a multiple nerve involvement electrophysiologically. So unlikely to be in the cord or trunk or the brachial plexus. You understood the point? Because the sensory loss in the median nerve in the hand of the index finger is coming from the lateral root of the median. Lateral root is coming from the lateral cord, which is again coming from the upper trunk. So unless that area is affected, you won't get a sensory loss in the median nerve. But ulnar snap can be absent by the lower trunk is affected, the lower trunk or the middle trunk is affected. And you can get all wasting of thenar, hypothenar, everything will be lost in lower trunk or lower root affection, but not the sensory loss. That's why in classical thoracic outlet syndrome, the finding is that you get wasting of all small muscles and involvement of the ulnar nerve snap, but sparing of the median snap. So this tells you the lesion is likely to be in the multiple nerve. Look at the points of this muscle detail, the upper and left spared. So final site of lesion, NC suggests affection of multiple nerves. Clinical NC local says multiple nerve plus myelopathy somewhere. And it's an MRI negative myelopathy. Whenever you get a myelopathy, pyramidal involvement with MRI negative thing, what possibility should you come to mind? Something like, motor neuron disease, but obviously it is not motor neuron disease. You know, he has got so much sensory involvement. It's not pattern, you cannot be a motor neuron disease. So you've got two systems are affected. Pyramidal system is affected, multiple nerves are affected within the CNS. When multiple systems are affected, always think of one possibility. It's a paraneoplastic. Because this is called tractopathies. It can selectively affect the pyramidal involvement in such patients or pyramidal of the posterior column. That's a part of paraneoplastic syndrome. He's also got a mononeuritis multiplex. You can have vasculitic neuropathy as a manifestation of paraneoplastic syndrome. So now this is actually, this MRI was taken not for the lung. It was taken for the, I wanted to view the plexus in this patient because the snaps are absent. Then we found out this lesion. It's got a malignancy in the right upper lobe of the lung. Okay, and that's the case here. It's got a CA lung with multiple, it's a paraneoplastic syndrome producing pyramidal tract involvement, tractopathy plus mononeuritis multiplex, probably vasculitic neuropathy.
Wow.
Okay, any questions?
So there's no infiltration in the nerves, no?
No infiltration, no thickening, no tenderness in the nerve, nothing.
Amazing.
And the presentation according to him was acute.
Yeah.
He attributes everything to the cannula installation.
Very nice.
Sir, if MRI, if chest CT was or MRI was normal, then could it be diabetic or any other causes?
No, how do you explain the pyramidal signs in this patient? The diabetic, and the problem is you can think of a diabetic mononeuritis multiplex, but usually diabetic mononeuritis multiplex, it affects the nerves in the pressure points like ulnar nerve or conperoneal nerve. That's a pattern they take. All the nerves involved in such a pattern will not occur in diabetic, that in both hands. You can have a diabetic plexor radiculopathy in the cervical region also, just like lumbar radiculoplexor neuropathy, but that is very uncommon, not uncommon. Again, the pattern is not fitting with a plexopathy or radiculopathy. It's multiple nerves are affected. That's first we localize where is it affected and then try to come to a conclusion.
Somebody is asking what is the HbA1c level? Was there a Horner syndrome?
No Horner syndrome. Absolutely, there is no Horner syndrome. Tennis are all perfectly normal. Anyone with a wasting of the small muscles of the hand or weakness, you have to immediately go for look for a Horner. It's a good point. Yes, no Horner syndrome. And moreover, the affection was bilateral.
And HbA1c must have been 8.
That I don't know because it's an old case of diabetes and nephropathy and all. It was done probably. I do not remember the value. But it's not going to help make a diagnosis, no? Diabetes is present in every.
Dr. Afshin wants to say something. I'm going to unmute
Yeah,
him.
please.
Dr. Afshin, you can go ahead and talk.
Sir, why not B12 deficiency causing myelopathy and concomitant peripheral neuropathy if malignancy was not seen in this patient, in some other patient?
Yeah, in fact, see, you got a point there. The B12 deficiency can someday predominantly present with pyramidal involvement with a lesser posterior column, as you see here. But you can, if you take the pyramidal plus peripheral involvement in the lower limb alone, agreed that's a good possibility. I don't deny that. But look at what has happened in his hand. It is in the mononeuritis multiplex pattern, not in the peripheral neuropathy pattern. B12 deficiency will not produce such a kind of involvement. It can involve the upper limb, but only posterior column can be involved. The upper limb can produce pseudothetus, etc., can occur. But this is not that pattern. It's a motor weakness and sensory loss exactly fitting with the nerve pattern, not the posterior column involvement of the cervical cord as you see in a subacute combined degeneration.
Okay, sir, thank you.
Yeah. Okay. Any other question?
The management part, should we treat the malignancy or can we give steroids for this multiplex type of presentation?
In fact, we are this case is only seen last week. We are planning a biopsy from that lesion and then decide accordingly. If it's a paraneoplastic, nothing is going to help him. You can empirically give steroid, but it's not going to help in paraneoplastic.
Of course, treating the malignancy might improve the paraneoplastic. So anyway, you have to treat the malignancy. So and hope that the neurological syndrome also improves.
Correct. That's the thing we have to do.
Sir, if it is normal, sir, then?
There has been some lesion there in that area. If it is normal and the biopsy comes as negative, we have to find out what is the lesion in the lung. If it had to be inflammatory lesion, then we have to think of other possibility. What is it considered? Maybe considered. You have to investigate for other causes of mononeuritis multiplex, vasculitic neuropathy, paraproteinemia. Those things we have to go in that direction.
Yeah, this lesion does not look like Wegener's granulomatosis lung lesion. It's not a vasculitic process.
And for more than that, over the 2 months, he has lost his weight so severely. You can see the body of the patient. Severe loss of weight in 2 months' time. Okay. Shall I go to the next case? Or you want to, shall I go? Sudhir?
Dr. Dugani wants to speak.
Yeah, please.
Yeah, this mononeuritis multiplex affecting both the upper limbs and absolutely sparing the lower limbs.
Yeah, correct.
Can you explain in that?
No, what you said is correct, perfectly right. That's a little odd. Why? That's why I brought the case. This is not the usual presentation. See, someday, tomorrow we don't know whether it's going to develop mononeuritis nerves of the lower limb also. These are all for 2 weeks duration.
It may progress to lower limb involvement also later.
Yeah, we don't know whether it's going to progress lower limb also. The upper limb never complained of. His complaint is only the left hand. So we picked up the fine in the upper limb.
Yeah,
and the lower limb examination is slightly hampered. It's already got a pyramidal lesion there.
Yeah, lower limb is only pyramidal. There is no element in the lower limb.
Yeah, no element weakness as such in the lower limb. It may develop later on, we don't know.
Yeah, that's a little odd, no, for the mononeuritis multiplex.
Yeah, but what else can you think? That's why the The neurology localization is like that always.
Dr. Dugani, it is odd. That's why when I said that it is unlikely mononeuritis because only hands and nothing in the leg, therefore I went for radiculopathy. But we have shown
But that is the closest explanation.
Yeah, correct. No, that's why we tried. That is why I initially in the LMN approach, I said can be root involvement, can be segment involvement, can be plexus involvement. Nothing is fitting with logically. That is where the clinical localization comes. It's only fitting with the nerve. Then come to the electrophysiology. Electrophysiology is fitting with only nerve. It cannot fit with any other site of lesion. But we know the nerves are affected. But what is the etiology? It's only a conjunction. So first, what we can as a neurologist do only localize. The etiology by investigation should come. But you know, each patient presents differently. Very many atypical presentations cannot. This case, I did not diagnose moderate multiplex initially. I initially thought myelopathy, probably cervical radicular myelopathy. That is initially. But after thinking about it in my home, after 2 hours only came to my mind, it is not fitting with the radiculopathy. Because the muscle pattern is not like that. It takes time for you to think and localize.
Okay, agreed. Thank you.
I'm just posting.
So Doppler was done, sir, upper limb.
I don't know. The pulsations were all normal in the left hip. Initially, I had the first thought was ischemic neuropathy, but the pulsations were all normal.
Madhu, interestingly, I've just posted an article where it is a CA lung presenting with paraneoplastic mononeuritis multiplex.
Yeah, correct. I did not know that. Thank you, Sudhir. I'll go through that. In fact, I would have taken in that.
But that patient had lower limb, because lower limb mononeuritis multiplex. But if you can get lower limb, why not upper limb? So
yeah, that's correct. Okay, shall I go to the next case?
Yeah, okay.
Yeah. Next two, I'm pressing two short cases. Not much of finding, both aspect finding confined to the lower limb. Let us see what it will take much time. 2 days back, this 56-year-old man developed headache and went to the local doctor who detected high blood pressure and was referred to the cardiologist. So the cardiologist examined him and put him on antihypertensive medication. Next day when he got up, he noticed that he has some difficulty in walking in the right foot. In that, the right foot go into inversion while walking. And the chappals gets slipped off and then came to me OPD. So this is the story. When he got up, he noticed that his difficulty in walking. The right foot is going to inversion while walking. And he's not able to hold the chappal. No sensory complaint, no pain in the lower limb, no root pain, no other complaint. This examination, and the upper limb score was normal. I will not spend much time on that. It's all normal. The lower limb tone is also normal. Reflection was normal. This could make mind is confined to the right foot alone. That will come to the left. This reflection was normal on the left side. On the right side is also normal. The dorsal was dorsal was weak. Inversion was weak. Inversion was weak. The inversion was normal on the left side. I'm checking the inversion on the right side. That is weak. Not inverted. Yeah, that's also weak. Inversion is weak. EHL was weak. That is normal on the left side. Then except longus was normal on the left side, weak on the right side. That is weak. Abduction and adduction was normal. reflexes is both knee and ankle jacks are absent. But bilaterally absent. Ask him to clench his hand again is absent. Both ankle jacks are also absent. But it is bilaterally absent. Its complex combinations are confined to the right lower limb. Plantar response was indefinite. Sensations were all normal. I will not spend time on that. Touch, pain, vibration, joints, and position sense, everything was normal. Okay, now let us see the gait of the patient. It's got mild foot drop on the right side. It was a little more gross on the first day. This is second day. So you can make out some problem in the right foot. Okay. So examination tone normal in both lower limbs. Weakness of right dorsiflexus, evertus, invertus, extensor hallucis longus, and flexor pollicis longus. Other muscles are all normal. DTR both knee and jerks and ankle jack absent, pandas interferate, sensory normal, SLR negative, and gait mild dragging of the right leg. That you can question my diagnosis, thinking it may not be there, because I thought mild dragging was there. Okay, what is the diagnosis? So what is localization and diagnosis?
The first possibility is the peripheral nerve involvement in view of right side foot drop with absent and or
Yeah,
sluggish reflexes,
right,
sir.
right. Okay,
Second
if it's a
possibility
nerve,
still is a, sir,
if it's a nerve, which nerve would you like to postulate?
the common perineal nerve involvement on the right side.
But his inversion is weak, flexor pollicis longus is weak. You can't get weakness of the inversion in the plantar flexed position in congenital palsy. And also flexor pollicis longus should not be weak.
So still a mononotice type of pattern, we
Yeah.
can have
You
a
can
space
think of
of the
if you want to explain that, you have to think of either tibial plus conperoneal or sciatic nerve involvement. But the point is that what would be the value of this absent reflex here? Because it's absent on the other side also. It was absent on the right side alone. That has got more value because that the disease side is absent, the other side is normal. Here it is absent bilaterally. So for that, the absent reflex does not have much of a clinical significance.
if the patient is diabetic, then we can have such patterns.
Yeah, agreed with. But even otherwise, some normal people can have absent reflexes throughout. We must have seen that some of them have, especially obese. He's not that obese. Generally, he can have absent reflex. I was also surprised his reflexes are diminished bilaterally. But he has no weakness on the left side. He has no complaint on the left side. But that reflexes are also absent.
The knee also is sluggishness.
Yeah, knee also is sluggish. Exactly, you are right. And to that point, again, there is no sensory involvement.
So could it be cortical lesion?
Yeah, cortical lesions.
Area.
Yeah, good possibility.
And the next day he improved. Looks like.
Yeah, it improved it perfectly right. But the problem is
So
you have
this,
to make a diagnosis at the first day itself. Because
sir, so this case is most likely is a cortical foot. Due to because he presented with a headache and his BP was slightly high. Probably some ischemic or hemorrhagic lesion
right,
in the
yeah.
foot
So,
area on the contralateral side.
right. That's what I also thought. Let us see the MRI of this patient. This is a diffusion weighted sequence. Normal. MRI brain. Sorry, player. Any other thing you want?
Contrast, sir. Contrast.
Contrast was not done. But Umar, what is it? I also thought the same only. Now I'll tell you what is it is correct. Because I did not show the uppermost. See, sometimes people will take only cut like that. Remember that particular point. This is not the uppermost cut.
Okay.
See, he has got a cortical foot drop. It is not the whole lower limb is not affected. So it may not span onto the middle part of the hemisphere. So what I like to think is that you have to go to the uppermost cut. So we got the uppermost cut now. See what is happening in the uppermost cut. It's got this two small infarct here and one here. I'll show this picture now. See, only at that foot area is affected. It's called the cortical foot drop. Okay. So that's why the reflexes may not be that significant if it's symmetrically affected. Okay. Now I'll go to the another case. Almost similar story. 60-year-old hypertensive lady. Her complaint started 2 days back. While she was standing in the kitchen, she noticed numbness, but not exactly paresthesia. Was it a pencil paresthesia? No, numbness, along with weakness of the right lower limb. She sat down and required help to get up and walk. Okay, this case is from Dr. Divya. Since that time, she noticed that she's dragging her right foot. Now, not to the examination. Yes, also no pain, no root pain, no low backache, nothing. No upper limb complaints, no headache, nothing. But hypertensive. Look at the finding. Reflection was normal. Right impulse was normal. Normal power. Dorsiflexion. AHL was weak on the right side. Subpolysis longus also weak on the right side. Inversion was slightly weak. The inversion was slightly weak. So it's got just like the previous case, but definitely in mind. But here the reflex is bilaterally brisk. And the briskness is equal on both sides. He also no complaint on the left side. Again, the plantar was indefinite. It was not neither upgoing nor downgoing. Okay. Sensory examination is normal. There is no pain level anywhere, no difference between the right and left thing. Vibrations was equal in both lower limb. Joint sensors also normal in both sides. So she complained of finished some no graphesthesia. She should name the letter down on the foot. Okay, let's get to the patient now. See, he's got severe, significant dragging of the right lower limb. No doubt, unlike the previous patient. Okay. Tone normal in upper limbs, both lower limb. Power weakness of inverters, EHL, FPL, all grade 4 plus. DTR both knee jerk brisk, angle jerk brisk, plantar indefinite, sensory normal, SLR negative, spasticity of right leg. What's the diagnosis now?
So it's a perineal tract involvement of the right lower limb, sir.
Correct.
But taking into the history of the positive sensory symptoms, one could be localized in the cord, or second is the cortical lesion, sir.
The sensory symptom, I should know why is it against a cortical lesion?
Because the sensory examinations, you showed the Graffes seizures and the cortical sensory loss is not there.
Yeah, it's not there. But in
spasticity is severe, sir. No, the spasticity, the presentation of 2 days or with such a spasticity.
The point is that, I'll tell you, what you said is correct. In the paracentral lobular lesion, you may get sensory loss, you may not get sensory loss. See, look at the previous patient. You don't have any sensory loss at all. There also sensory loss is not there.
So for such a spasticity to occur over 2 days duration, so more of a worsening of old myelopathy can be there, no, sir, cervical.
He had no complaint prior to that. All complaints started 2 days. Just 2 days only complaint. It's only confined to one lower limb. And that too
such a spasticity cannot occur in a cortical lesion for a 2 days duration. No,
no, that can occur. That depends upon which area of the cortex is affected. That can occur. If it's acute zero power, then severe significant weakness or severe affection of the nervous system, there can be hypotonia secondary to cortical lesion. The so-called neuronal stroke. Otherwise, a mild affection can have spasticity. Nothing against that. So as you said, it's correct. It could be in the cortical lesion, or it may be in the pontine lesion, or it could be in the cord lesion. But you said is so here it's got a perimeral involvement in the right lower limb is definite. It may be in the cortex, the paracentral region. It may be the pons, because in the pontine lesion, the pyramidal fibers are segregated into bundles, anteroposteriorly located. Sometimes it may be confined only to the upper limb or only to the lower limb, or lesion in the right thoracic cord. What you said is correct. Agreed. Now, where is likely etiology in this patient?
more likely cortical in view of absent sensory, sir.
You think it's a cortical involvement? Okay, like a say infarct. It's a possibility, just like your previous patient. Anyone else want to think of anything? Any other possibility? The problem with cord involvement is that it's affecting only the right perimeral tract. So usually in involvement ischemia or we expect the adjoining tract, spinal thalamic tract to be affected, where you get a sensory loss on the opposite side. Should be on the left lower limb. If at all the patient is complaining numbness on the right side, not on the same left side.
So in previous case, also shown some spinal artery branch involvement. They can also show focal cortical involvement of the lower limbs.
Yeah, perfectly right. Spinal involvement, the sulcocametal artery involvement can produce involvement of only perimeral tract on one side, but they will have invariably affection of the spinal thalamic tract also, because the sulcocametal artery supplies the perimeral tract and the spinal thalamic tract. So you get sensory loss on the opposite side, unless it's a very focal ischemia to the perimeral tract. That very unlikely for a sulcocametal artery involvement. Because the area of the territory supplied by the artery involves both the two. But obviously posterior column will be spared. Okay. So what investigation you want to do? First of all, I thought initially from the instant finding, I thought it would be parasite lesion like an ACA occlusion. So this was done 24 hours later. The MRI brain is normal, division is normal. So I was not satisfied. I wanted to do a repeat MRI after 24 hours again. I want a coronal cut not to miss any cortical infarct. There is no cortical infarct in this patient. Then what else you want? You want cord lesion, no? MRI of the spinal cord. MRI spinal cord is the MRI here, this axial cut, the corresponding level here. So what do you want? In fact, we have got a very good radiologist, and we also suspected a cord lesion because she picked up some sensory level at that level, which I did not pick up when she brought the case to me, because I saw the patient the next day. So radiologist did a special cut, thin cuts, the D4 level. And you know what he picked up? A small dot of hyperintensity in the cord here. Can you make out that hyperintensity? Here also seen on the right side of the cord. You can make out the arrow is pointing to that hyperintensity here also. You can also make out the hyperintensity here. I'll come back to the, with the contrast, you can clearly make out the contrast enhancement on the right side. That also you can make out the contrast. Okay. Here again you can make out. So it's got a lesion, very small lesion on the right of the cord. Now what do you think about that etiology? There's no sensory. I rechecked the sensation again on the second day. There's no sensory involvement in the contralateral lobe. What could be the etiology in this patient? Acute on.
Vascular, and there is a focal demyelination, so in the view of acute presentation.
Yeah, correct. Vascular but demyelination, you know what usually happens is that by the time the deficit occurs, you get clear-cut evidence of signal changes, not only confined in focal area, usually a diffuse involvement. Even acute transverse myelitis, you can usually get a long essence of hyperintensity, at least spanning out 2-3 segments, and that should be bilateral. You can have demyelination confined to one side of the cord, but the findings may be one side, but MRI was little more extensive. So that's not clear to your point. Agree with you. That's a point you have to keep in mind. So you want a CSF study?
Sir, one more thing, because she was working in the kitchen. So
yeah.
Is it possible that she weighted some? She must have lifted some weight and caused a fibro cartilage.
No history like that. No history like that.
Okay.
So in the cord, which area could the radiologist tell you antipod or
D4 level?
No, sir. In the cross-sectional area, sir. In the which part, in the hemiside or in the center or in the sensory area?
It is on the right side as well as slightly posterior. On the right side and slightly posterior, but not very posterior. It's not convincing, but right side is definite.
So could it be the vascular in a view of the focal and the branch spinal artery involvement?
Most likely. So see this MRI, if at all you can explain the lesion, just be vascular only. I don't think it is demyelination. Anyway, to exclude demyelination with the CSF study also, CSF study is normal. Okay, I'll go back to the cut again and show you one more things. Now concentrate, remove one by one. Do you find any pick up any abnormality anywhere? Did anything strike you?
It's a dissection of the aorta, sir.
I said a hematoma in the aorta. This is the diffusion. Diffusion is restriction, but that's not very reliable. Now I checked the patient once again for any level. As Divya was telling, there was a level initially, but I did not get any level at all. Subsequently, also I checked the level on the trunk. It was not there. And the back and front also examined. There is no level, nothing. So sensation is centrally normal. Now I always look for the spine MRI for an infarct because the usual involvement of the D4 segment is artery of Adam cubic involvement or the radicular artery involvement and the affection in the watershed zone. And if you get an infarct in the vertebra, there's an added point telling you that the lesion in the cord is ischemic. There was no lesion in the vertebra. But now look at carefully in the aorta, there is a hematoma in the aorta, dissection in the aorta. There's hematoma in the mural hematoma, but you can see here. You can also make it see here. Subsequently, the radiologist took a CT scan of the aorta to find out whether the hematoma was acute or not. It was an acute hematoma spanning over 3-4 segments. So most likely this hematoma is occluded the orifice of the Adam-cubic artery partly, producing focal ischemia in the pyramidal tract on the right of the cord. Extremely uncommon presentation, but this is the localization. It's where in the parathalamic tract. Okay, any questions? I think Sudhir has left, I think. Sudhir? I'm not getting any comment from Sudhir. Yeah, any opinion?
Does she require the DSA of the aortic and other low limb arteries?
Right. In this case, this is saw the case only yesterday. Yesterday only I knew I was told about the acute hematoma. I did not even see the film. I was about the film of CT scan. So we are planning an aortogram and then consulting a thoracic surgeon recording in a surgery. Most likely it may not record in surgery, but we are planning. Tomorrow I'll be going and planning that.
Sir, was there any pain, any acute pain or something?
Nothing. Is no pain, no backache, nothing. And only see first see when the patient is brought to me, I thought it's AC occlusion. If there's negative only, I consider this possibility. The other side which can occur is remember spondylitis also can sometimes present with one limb involved. These are three sides where you can think of a monoplegia like presentation. Especially of the lower limb. Okay, any other questions? Comments?
Great cases, all fantastic cases, sir. All learning cases only, sir, because every day.
These two cases in 1 week apart, both right lower limb and two different etiology. That's what I thought I'll bring the case. So I'll stop here. If there are no questions, shall I wind up? Okay. Sudhir has left, I think. Mansi? Okay, then I'll stop. So thank you for your patient listening.
Thank you. Thank you very much, sir. Thank you, sir.
Bye.
Thank you, sir. Thank you.
I'm here. I'm sorry. I was unable to unmute myself.
Yeah. No problem. No problem. Okay.
Yes, sir.
Thank you, Mansi.
Okay.
Okay. Bye.
Yes, thank you, sir. Bye, sir. Dr. Kabir, you want to say something?